I had two speakers from here. One of the emergency room physicians there, Dr. Ndadi Regis, who went and spoke about emergency infectious disease in Nigeria, Lagos, Nigeria. And Dr. Golan, who's spoken for me about 2 or 3 times here, who spoke about infectious disease in the developing world. It was wonderful. It was an eye-opener for me that the opportunity that we have here in America, other parts of the world, when they have it, they're grateful. They were very grateful for what we were able to do, and they've asked me again, to come back again. I said I have to think about it. I said I'll do this event here, this year, this December, then we can talk about it. But this evening, I just want to tell all of you that, you're not here by accident, Each one of you that is here tonight, you're very special to me. I really appreciate it. It's not every time that people get invited to places that they go, you must think that there must be something special about the event and about me, for you to come and honor me. I really appreciate each and every one of you, okay? So, this year, I'm going to start out with a video, like 10-15 minutes on what happened in Lagos, Nigeria. Just for you to know that Africa is not what we think it is. We are good, I'm telling you that. You're going to see it, okay? And after that, I was hoping that some of the... Is anybody here that went to Nigeria with me? Except my wife. But I'm still going to come. She went with me, yeah. And it was good. So, Toby, where are you? Toby!
Yes, sir.
Can we dim this light, here? Can we dim this light? Dim the light. So anyway, the format this year, like I said, you're going to watch this video for like 15 minutes. Then after that, everything that happens in the life is not by accident. There's a reason for it. I invited the professor of infectious disease here, and for some reason, he said he had some family values that cannot argue with him, Dr. Stevens from Mason. So he's not going to be here tonight. Don't be disappointed. The brains that are assembled here is more than one brain, okay? I have top-notch infectious doctors here who is going to take your questions on everything you wanted to know in infectious disease. I've always thought that it's actually more engaging if you can ask questions. Either you get up or you can write on a sheet of paper and I read it as a moderator. And the specialist answers the question. I think it's more engaging than just talking about one single topic that you listen to it and you go and you forget about it, okay? So this is what we're going to do. So, pharmacist and Dr. Valerie Fletcher. She's my competitor, I'm very generous. I call my competitor to come and talk where I am. Isn't that good? Okay, my colleague. That's what he calls it, okay? That's good. Dr. Malwich is not here. Okay, come. Dr. Bushakin, whenever he gets here, we'll get him on the stage. So please start getting ready to start asking questions. I had to do this because, like I said, I thought it was going to be more interactive, more interesting to have interactive questions. And I wanted to, of course, conserve some fun because it doesn't make any sense paying a speaker so much money, to just come and talk for 30 minutes or 40 minutes. So I think tonight is going to be a very enjoyable night. I've seen some people who never believed in me who are here tonight. Dr. James Cunningham, where are you? Where are you going, James? Thank God, he always misses it. He tells me that I give a wrong date. Please clap for this young man.
It's true.
What's that?
It's true. I've tried to get here for a few years, and he keeps giving me the wrong date. I've shown that.
Talk.
It's true.
It's true. I mean,
Yeah. He always tells me that I
But
give the wrong
told
date.
the truth this year, so I'm here and we're going to enjoy
That's
ourselves.
good. Thank you. Okay, who's going to go first to ask the panel a question? Anything you wanted to know in infectious disease? that's always confused you. We've done this 4 years ago. I would hate to call people because I can do that too. So, who's going to go first?
Well, I got a question. Recently, there's been some news about some nurses who got fired from the hospital who refused to get the flu shot. And I guess what they're saying is that there's no proof in getting the flu shot prevents getting the flu and affecting patients. So, is that true?
So your question is there any benefit in getting flu shot?
Right.
Why do you have to force to get flu shot?
Fired for not getting it. It was in the news.
Okay, good. Who wants to answer the question? Valerie.
Thanks, Larry. So I guess the firing is something you have to address with HR. What usually happens is if the nurses or physicians refuse to get the influenza vaccine, they're asked to wear a mask during the whole season to prevent transmission to the most vulnerable our population, who are the elderly, usually, and the children who have no immunity, who are hospitalized. There is sufficient data to show that the influenza vaccine, if it's a good match, and a good match means that it protects in the region of 40 to 60% of the time. If it's a good match, because it's strain specific, that it is very effective in preventing influenza infection in the person who gets the vaccine, and it also prevents, in that way, it prevents transmission to other people. Some people are unable to get the influenza vaccine for one reason or the other, and giving it to the person who is a caretaker protects the person who is unable to get the vaccine. I'm sure you heard the recent news came out 2 days ago that the vaccine this year will probably not be a good match. In the southern hemisphere, where they just had their big outbreak, the match is about 10%, right? It protects about 10%, and that is not a good match. And so we expect to have a really bad season this year. But for people who have been getting regular vaccines, they will have more protection because they have been exposed to so many different strains in the vaccine. They'll have more protection than the person who does not get regular influenza vaccines. Yeah.
And I'll just add to that, definitely there has been cases of horizontal transmission from healthcare worker to patients, and that is absolutely a fact.
Thank you very much, Larry and Dr. Fletcher.
My question is, do we need to do the shingles vaccination if somebody already has a shingles? And if it is yes, then when? I mean, how long do we have to wait? Somebody already has shingles.
Well, yes. It's you can give the shingles vaccine after somebody has had the shingles vaccine. You can wait till several weeks, it depends, okay? But it's recommended that you can give it to them afterwards, okay?
The original trials were actually done in shingles naive patients, but then the follow-up trials 2 years later that began were patients that had a history of a shingles outbreak before, and what the outcome was that they were looking for was a reduction in recurrent shingle events, and it did reduce the recurrent shingle events. So it is definitely, like Dr. O said, recommended even after a shingles.
And there is a new shingles vaccine, I'm not sure you're aware of that. It was just approved by the FDA and the ACIP. It is not a live virus. It is a recombinant virus, and it protects. It is far superior to the current live virus vaccine. There are 2 doses. It is recommended for patients over 50 And in patients over 50, it protects up to 97%. It's effective up to 97%. And as opposed to the live virus vaccine that is about 50% effective over 50. In patients approaching 80, the live virus vaccine is only effective in about 18%, while the new vaccine is protective in up to almost 90%. Okay, so there's that new vaccine, and I think we're just waiting on the insurance companies to decide to pay for it, but it has been approved in the past few weeks.
So do we have to repeat the new vaccination to the people who already has the old vaccination?
It is recommended for patients who have already been vaccinated with the live virus vaccine.
But isn't it the current vaccine is also live?
Pardon?
The current vaccine for the singles is a live virus, attenuated live virus.
It is a live virus vaccine.
Right.
And I think they're probably going to phase it out.
Okay. Thank you.
One more thing that because it's those are tropical countries, that's why we have the incidence of malaria infestation very high. But when compared to other areas, other tropical countries like Malaysia, Indonesia, and the southern India or Central America, the incidence of malaria is not as prevalent there. What are we doing to eradicate malaria in the West African countries?
Well, that's a very loaded question. Very interesting. One of my speakers that I had from Nigeria, the Deputy Vice Chancellor of the University of Lagos, spoke about malaria. And it looks like as long as public hygiene is not good, standing water, puddles of water that are not flowing, tires that are left in places that water stays in there, this mosquitoes can breed. It's going to be a big problem. So the government is trying to do that. In the good old days, they used to have they call them wole wole in the good old days. That's a Nigerian term, but these are inspectors that go around, and when they see in your house you have probably a keg of water that's open and there's larvae or mosquitoes breathing there, they find you an outbreak. Things are getting to that stage that public officers are being sent out now to make sure that the environment is clean and clear, and water that's not flowing is made to flow, which is a big problem in developing countries because of the planning that is not there. Houses are built on places where waters are supposed to flow, and it's going to be a big challenge, but the government is trying their best. Any other question?
Doctor, as a follow-up on this question, is it that some people might just be susceptible to malaria? Because there are some people that I don't think this poor sanitation applies to them. I do have cousins that maybe on a monthly basis, they come up with malaria. So is it that they're just susceptible to it? Not necessarily poor sanitation.
Well, I don't know what your cousins do. I mean, if you go out at the evening, you are not wearing long sleeve shirts, you get bitten by mosquitoes. I don't know the kind of job you do. Of course, you get exposed. You probably have malaria. Yeah, there are actually some individuals that have, I would say, resistance to getting malaria. Like the sickle cell patients, and there is a particular blood group type that, for some unclear reason, malaria parasite can affect them. So, of course, if you get exposed, it depends on your exposure. Either if your environment is good, but there's still mosquitoes that kind of parasite. If they bite you very often, you're going to get the malaria. nobody's writing down
I
anything.
have a question.
Yeah. Toby, you can come and give us the.
So, I was actually going to ask a question about whether or not you have some of the latest information on the malaria vaccines or vaccines candidates.
The conference that I said I had in Nigeria, the professor there said the trials are ongoing, but the final word is not out yet. So actually our center, University of Lagos, is one of the centers that are trying this out, and the word is not out yet, and it's still in the pipeline.
I have a question. So, out of curiosity, where do most of your referrals come from? Because I noticed in Augusta, most of the referrals come from hem-onc type patients, and other places it might be ICU or surgery. So, in your hospital, from what you've seen, where do most of your referrals come from?
Look, I'm going to answer this question, okay? This is my daughter. She's a medical student. Don't ever try to say you want to be infectious with me, okay? I'm just telling you that, so, but I'll tell you where my reference comes from, okay? I'm just telling you the truth, okay? Do dermatology, okay? But anyway, we get referrals from all over, general medical floor, orthopedic floor. Hematology and oncology, yes, but most of our referrals are, are from the family practitioners, or the hospitalist. We have hospitalists here who refer patients to us. Okay. There is an orthopedic hospital here too, where they have a lot of joint infections, prosthetic joint infections. You get to consult from there too. Okay. We have a lot of HIV patients here too. I have a fair number of patients with HIV that I manage, and Dr. Fletcher manages too. Does that satisfy you?
Yes, thank you.
Any other question?
I got two questions. One is for Dr. Tabbs and the other one is for Dr. Fletcher. Dini, can you give us an update on febrile neutropenia? And Dr. Tabbs, if you listen to the commercial, there's a commercial that says 1 in 3 baby boomers is infected with Hep C virus. What should primary care physicians be looking for? Because like everybody in this room is a baby boomer.
No, I don't think that question is very appropriate for Dr. Tal.
No, the first question is about
Let me talk about febrile neutropenia, okay? What is neutropenia? You first of all have to find absolute neutrophil count less than 500. Fever that has been ongoing for several days that you really don't have the clear source point. Most of these patients are patients who have probably cancer or on chemotherapy, who drop their white neutrophil count abruptly. And what happens that with the neutrophils, if you drop it abruptly, that's one of the things that protects you from infection. And you have to, of course, take a very good history, When was the last time the patient got the chemotherapy, how long has the fever been, and all the rest, going through the charts, the medication they're on. Of course, and you need to have to, of course, be able to examine them. A lot of times, most of the time, with very good examination, and from talking to the patient, you might be able to have a clue to what's causing the fever. And sometimes the fever gets very difficult that you have to do other studies like, probably doing CAT scans, and doing MRIs and doing nuclear scans and all the rest to see whether there's any hidden source of infection. And sometimes too, it may just be the cancer itself, that is causing the fever. So there's a lot of thinking that goes into febrile neutropenia. And a lot of times, if you look very well, an astute physician will be able to know why the patient is having a fever. But sometimes, just the fact that they're actually neutropenic. Some patients just have fever, and you look and you can't find the source. And when their white count starts going up again, the fever resolves. So it's a very broad spectrum topic that is not something that you can just gloss over that without being a very good clinician and somebody that is very accustomed to working up patients like that. Okay?
I'll add to that as far as, how does the institution help and assist in antibiotic selection? Whenever, so we do have annual antibiograms that we put together in order to characterize the epidemiology in an institution and the patients that are coming in. But even more so in the cancer population, we do stratified antibiogram, especially for the oncologist. We'll do stratified antibiograms for a certain floor that has a heavy amount of oncology patients. And then we'll look at the epidemiology and determine, which agent is going to be the best agent from a primary standpoint. So you always want to cover the Enterobacteriaceae Pseudomonas. So we look at those agents, such as ceftazidime or cefepime, and in some cases we even have to, look at meropenem to see what's going to be your first line therapy. And then in our antibiogram, we also, in our empiric guidelines, we'll also determine, what cases or what has to be present or should be present for you to go ahead and add vancomycin and have that staph coverage at the very beginning, as opposed to just that gram-negative and strep coverage. So we do these stratified antibiograms and work with the oncologists and work with the providers, the ID physicians, as a multidisciplinary team in order to provide the best information, for all of our febrile neutropenic patients that are coming in, especially those that are coming into the ETC that are hypotensive and septic. All of our emergency room providers and hospitalists and residents, they really need to know what's tailored to your institution. And I'm really proud of the level that we're able to practice and what we're able to provide to help all the patients that come to our institution.
So who do you screen for hepatitis C virus infection? I think that was the question. Where is she? Good. Okay. So it's all about risk. And if that patient is high risk of having been exposed to hepatitis C virus infection, then that patient should be screened. But there are a lot of patients who think they have not been exposed, who actually are hepatitis C virus infection, but hepatitis C infected. So you have to think of how the virus is transmitted. It's transmitted through blood, it's transmitted through injection of drug use, it's transmitted sexually, body fluids. And if patients have any history that suggests that they have been exposed, then they should be screened. I don't think we're at the stage yet where everybody needs to be screened, but I think we're probably getting there.
Well, when I talk about the people that were born between 1945 and 1965, the baby boomers, they said they should do the test for them at least once if you documented they never had it. Because they say 1 in 5 of them probably has it, yeah. So,
risk.
I mean, that's what they say, but I've done a lot of the tests, and I've been able to pick up a few. And I've been, because you can cure hepatitis C, and that's the main reason of trying to test them, and so you can offer them treatment. Look, I have to introduce somebody to you here that is very important to me. This is my friend. He's about this for the last 10 years. He's a nephrologist from Maryland. He said he had to come here. He flew in today to surprise me, and I just saw him walking. Dr. Osman and Mr. Osman, please could you get up? He was my best man when I got married, and I was best man when they got married. Dr. Osman. Any question again?
I have a question. It's regarding Lyme serology testing and misdiagnosis of Lyme disease. Of about 10,000 people who have been told that they have it, about 30 people actually have Lyme disease, and that number varies depending on which study you look at. But my question is, what is being done or what more could be done to prevent misdiagnosis or unnecessary treatment of the disease?
Well, I'm going to be talking very much this year because 4 years ago, when I moderated, Dr. Fletcher accused me that I did not answer a lot of questions. So I said this year I'm going to answer a lot of questions. Okay. Kindle is my scribe. She works with me in the office. So she knows dilemma with the patients who come in with the referral Lyme disease. Number one, as you have seen, that there's not been any single person since you've been with me that we've confirmed that has Lyme disease. No. Most of the time, the providers and the lab, most of them don't know how to interpret the Lyme testing. The guidelines say that, it's like a two-step testing. You do the Lyme serology, you do the IgG, ELISA, and if it's positive, then you go ahead and confirm it with the Western blot. In the Southeast here, Lyme disease is not common. We are not saying it doesn't happen. But in the Northeast, Boston, New York, Delaware, to Maryland, that's corridor. There's a lot of Lyme disease there because the vector that carries this disease is very rampant there. Of course, we have ticks in Southeast here that carry other kinds of spirochetes, that are very similar to Lyme disease. We have and what they do is that sometimes those testing it cross-react a little bit, but you need to know how to read the bands. It says that you have to have 5 bands out of many bands. And we get referred with patients who have only 1 or 2 bands, and they say they're positive. So you as a physician, number one, of course, somebody that has not been bitten by ticks, you can never know, or that has not been out of Georgia, that comes into office with 1 band that is said is positive, you should be able to be comfortable to say that this is not Lyme disease. And there are some of the patients that, before they come in, they've gone to so many providers and they've been told that they have the Lyme disease, and they're just waiting for you to confirm that they have Lyme disease. You should be able to stand and say that, from the guidelines, you do not have Lyme disease. A lot of times, there are some other reasons why they're sick, and that's what we need to work on. Okay? Does that answer your question? Go to Ken.
So the Infectious Diseases Society does not recognize a diagnosis of chronic Lyme disease. And I think that may be one of the other things that you're getting at, where patients are referred as having chronic Lyme disease and they need to be on doxycycline or ceftriaxone for a year. We do not recognize that diagnosis. The treatment of Lyme disease that's uncomplicated is up to 28 days of doxycycline or ceftriaxone if it's complicated, but there is no continuous treatment after that. Patients may have symptoms that are non-specific, and it may be called a post-Lyme disease syndrome, but there is no antibiotic therapy that's recommended for that.
Thank you, Dr. Fletcher. Any other question?
The CMAP trials that are going on in West Africa, I was hoping that you had a little more information that you may have had since your specialty is different from mine.
Well, look, the news about Ebola is all over. I mean, it happens once, anywhere, you hear it all over the world. There was a little scare some time ago, somewhere in West Africa, but I don't think it panned out, not long ago. I think it died down. But we're happy that the epidemic that happened the other time is down. But this thing can come back again, we don't know, but right for now, it's very, very quiet, and that's how much I know about it. You don't know anything about it? Is Dr. Obushake here, please? Obushake?
Hello. I wanted to know, what were your thoughts on alternative medicine when it comes to infectious diseases?
What did you say? Alternative medicine?
Alternative medicine.
I'm not sure I can answer your question. I do not usually recommend alternative remedies when I am taking care of patients with severe infectious diseases. But there are other people who may have different opinions. I know in some parts of the world, like in Germany, they use a lot of alternative medicines that are apparently effective, but I'm not an expert on that.
Okay, thank you very much. Any other question? Dr. Cunningham, I'm still waiting for you to ask that question.
One question I have, Dr. O. Over this way. Dr. O. This way. I have been traveling to Uganda, Africa for the last 18 years, and this is the first year that it was mandatory to show documentation that we had yellow fever. My question is there a global outbreak of yellow fever, and is there a expiration date for the yellow fever?
Yeah, well, yellow fever vaccine is recommended for those countries where... Can you hear me? You can hear? No. No. Hello? Okay. Yeah. So yellow fever, like the viruses that we talk about, they're very interesting. They have geographical distribution. There are certain places where it happens. So if you're going to those places, of course, the country that you're going to, has the responsibility to ask you that you vaccinate before you come to the country, because you could get exposed and you'll be sick. So there's no, it's just a very wise thing to do, that if you're going to a country that you need a vaccination for, you need to get it. I think probably it's about 10 years, every 10 years. Yeah.
I think there have been outbreaks in parts of Africa. I'm not sure where in Africa, and South America. I think one of the big things is that there is a shortage of the yellow fever vaccine, and they have been giving half doses instead of the full dose. But there is a shortage of vaccine, and I don't know if that is the reason why we're having these outbreaks now, but there are a couple of outbreaks.
Okay. Jelk, thank you very much for the work you do in Africa. Jelk goes to Africa, takes tons and tons of shoes to underprivileged children in Africa. Please give it up for him. He's done well. Did Tamara want to ask a question? Tamara? Where's Tamara? Where's she? Oh, I don't know her again. Oh, man, Tamara.
Okay, quick question. Can you comment on the usefulness and utility of this procalcitonin level that we see a lot used in the ICU, and especially the appropriate way to interpret it, please?
Yeah, that's a really great question. There are two ways to use procalcitonin. Certainly, one, whenever you're using it adjunctively, with other things like CBC and vital signs, especially in patients that have service criteria, and you're trying to identify, is it infectious etiology, and, you know, does that patient have, you know, infection, sepsis. In a case like that, it is best for you to actually obtain the procalcitonin within the first 24 hours, because when you start antibiotic therapy, you're going to miss the peak, and by the time, if it's a send out, by the time you get it back, we looked at the turnaround time. It's about 170 hours is the turnaround time whenever you send it out. If you don't have it as an in-house assay, then it's really not clinically useful, because there are actual cutoffs that it's important for you to be able to see, you know, what your value is, you know, within at least an hour or two, if you're going to use it with all the other parameters that you're looking at. So that can assist you in making the decision, does the patient have viral etiology for their presentation or bacterial etiology? So there is a clinical pathway that we have at our hospital that's going and pending MedExec approval. And once it's approved, then we'll put it on our internal antibiotic stewardship website and make that available for all the providers. The second way that it's recommended in clinical trials to use procalcitonin is to assist you in setting your antibiotic duration of therapy. So in that scenario, you're going to want to take your baseline within the first 24 hours, and preferably in a case like that, it's going to be a patient that's going to be transferred and require management in the intensive care unit. So your second procalcitonin is going to be roughly 72 hours later. And at that point, if it's moving in the right direction, that is valuable in helping you to feel like you have the patient on the right empiric antibiotic therapy. The third procalcitonin that's obtained 72 hours after that needs to be reduced from baseline about 80%. In order for you to feel like, you know, you've really, the patient has really moved so far in the right direction that you can go ahead and set your duration of therapy to the lowest evidence-based duration for that range of the primary infection. So if they have a healthcare associated pneumonia, and you know you can go anywhere from 7 to 10 days, if that third procalcitonin is supportive that you have moved in the right direction, then you can actually set your duration of therapy to that 7-day time period. So I am happy to say that we're looking at some new machinery now, and I've already checked. The procalcitonin assay, Dr. Cunningham, is on this new assay. So I was given the word today that we should be having an in-house procalcitonin test as soon as we purchase these new instruments. So we're really excited about being able to apply them real time.
Just wanted to add to that we should not use the procalcitonin level as a marker, well, in the diagnosis of sepsis.
I agree with your perspective. Yes.
It's an adjunct.
Yeah.
They can't use it to diagnose sepsis.
I've seen some people dying from sepsis, post-blood culture, all sort of things, and people
I did want to ask a question because, ever since I've been in critical care, these patients get admitted to the intensive care unit. They're screened for MRSA. They do the nasal swab, and if this comes out positive, these patients are put in contact isolation. Everybody is wearing their protective, the little yellow gowns and all. But some of the latest that I've been reading, at least in the critical care literature, and some of the others say this may not be cost effective. We may not really need to be doing that. Instead, we may need to consider, high-risk patients and maybe even using mupirocin, Bactroban, and just doing it for everybody and not doing it. I was just wondering what the panel thinks about that. Are we really spinning our wheels doing this on everybody, making everybody wear these gowns and all? Is it really making a difference? Or should we just wash our hands, make sure we good technique? I just was wondering what y'all thought.
Right, it makes some people feel good. Gowns have never been shown to reduce the transmission. Hand washing and gloves have been shown to reduce the transmission of MRSA. The nasal screening is good. However, we're overlooking the fact that MRSA is also found in other areas. So it's found in other areas of the skin and the perineum, and we're not screening those areas. There are healthcare workers who also are carriers of MRSA, and they're not being screened. So I think there's a little bit of a double standard there, and we are really not doing any good by isolating patients who have positive nasal sprays.
I have a question. Are we seeing improvement in morbidity and mortality from starting the sepsis bundles mandatory in the emergency room? And what is the clinical utility of repeating the lactic acid level within like 6 hours?
So definitely for the Surviving Sepsis campaign, there's really good literature that if you do roll out the whole bundle, then there is a reduction in mortality. There's no doubt about that. I think a lot of the processes that we have in our emergency rooms throughout the United States, starting at the triage table, is the right way to go. But we do know that it has high sensitivity and low specificity. We're casting the net really wide. We're screening a lot of patients. And we know, that there's no single test that we can do in order to identify those true patients that really would benefit the most from the bundle. So we are expending a lot of time, but it does save lives for those patients that really are in that intermediate hyperlactemic state, and that's that 2 to 4 range where their compensatory mechanisms are really great. If you looked at them, you would not be able to identify them as overtly severely infected, and it is identifying 25% more cases. And in those 25%, if they're not identified, they go on, that 25% will go on to develop severe sepsis and septic shock. That second lactic acid, there's a lot of debate, and I brought that up at the last meeting I was at with the CMS folks, because CMS is really driving that second lactate level. And there's only 2 studies, and they're very not strong studies for the repeat lactate. So there's no data from the studies that, if you have a lactic acid level that still continues to be elevated, that you need to go ahead and repeat your 30 milliliters per kilo, that you need to do anything different about management. But what they're stating is they hope that with everybody actually getting that second lactic acid, because it's now a core measure for everybody to get these, that we'll actually learn the clinical utility of that lactic acid and how to best help those patients that may require more intervention at the 3-hour mark. So we're going to see a lot of data come out about that second lactic acid. It's unusual for it to be required first and then for us to see data. I haven't seen that happen before, but I think we're going to learn a lot from it. I do. Thank you for that question.
The biggest problems that I run into is trying to convince them that just because you have a hole in your foot, it's not necessarily infected, especially since it's being treated. How would you recommend we go about trying to get them to calm down and not demand the antibiotic?
That's a really good question. And actually, that's one of the core elements too, is being able to use effective education with your patients to be able to convince them that the side effect of the medication is worse than using the medication and receiving any benefit whatsoever. So the newest recommendation is really it's interesting in the respect that the whole focus is for you to really tell them about C. diff colitis. So the sheets, the information sheets, it's not just about, hey, you have a virus or you have this and you don't need an antibiotic and you won't benefit from it. It's literally to scare them that they could end up with a worse event than what they started with. So really talking to them openly about, in layman's terms, about the pathology of what they're looking at, and then let them know that C. diff colitis can be a side effect of the antibiotic and that it can be deadly and that there are 500,000 cases annually. So we actually have different education sheets now that are geared towards that. It's interesting, CMS wanted us to actually, or the CDC recommended that we give it to patients while they were in the hospital. But they relaxed that core element whenever I went to IDSA a couple of months ago. CMS stated that they completely relaxed that and they removed it because they felt like it would be a conflicting thing to tell a patient that is ill and in a bed in a hospital, you need this antibiotic to get you through this sepsis, but it can cause a life-threatening C. diff colitis. So now they're stating that they want evidence to support that we're doing that at discharge. They're going to be focusing on appropriate patient education at discharge to include information about C. diff, so then that way they can know when to follow up if they end up with signs and symptoms consistent with that event.
Thank you very much, Dr. Cha. The night is going very, very fast, and I think I see a lot of people yawning already. So I think I'm just going to read this last question, okay? And we'll answer it. I understand the video we can show, but I'm not going to ask you to sit down and watch it. We're going to start eating, it will be running, you can see it, and we'll start eating so the night can go on. The question is this: why is it that some people get the flu within weeks of getting the flu vaccine? I've only had the flu twice in my life, each time within weeks of getting the vaccine. Well, very interesting question. How do you know that you had the flu? That will be the first question. That's true. Did you prove it that you had flu? I don't know. The fact that you had runny nose, you are feeling weak and all the rest doesn't necessarily mean that you have the flu. If it's not documented, what did you have a rapid flu test done? I don't know. So this is going to be a very difficult question to answer. I mean, if you have a documented flu after you've had it, the shots will be very interesting. And there's something about vaccinations. Vaccinations are not 100%. Vaccinations are supposed to be like you are going to a war and you have an armor that can guide you, protect you from being shot, okay? You go to a war, you don't have an armor, you can get shot easily. So your vaccination is to provide some antibodies, some fight for you if you ever get attacked by these viruses or bacteria. So there's no vaccination in the world that is 100%. So you can get the flu vaccination and still have the flu, but your severity of illness will not be as severe as if you have never had the flu vaccination. Is that clear to the person that answered the question?
So can I add to that?
Yes.
So the influenza vaccine that you get intramuscularly is not a live virus vaccine. It is a killed virus vaccine, so it cannot give you influenza infection. The vaccine takes about 2 weeks before it becomes fully effective. And so during that 2-week period, you can get influenza infection, and it will manifest, as Dr. Oluwale says, it may manifest, well, it may not be as severe as if you did not have the vaccine. But as I mentioned earlier in the evening, the vaccine is effective in probably 40 to 60%. That's the efficacy, 40 to 60%. It's not 100%. The circulating virus that is expected for this year, called H3N2, is expected to be the same virus that was seen in Australia for their influenza season. We also use the same vaccine that they use, which is specific for H3N2 strains, and their efficacy was 10% for this season, 10%. So we expect the flu vaccine to be 10% effective for our season. Now, we're still recommending that everybody who can should get the influenza vaccine because it is protective, but it's not going to be as effective as the vaccine that we had last year. It is more going to be like a 2009 flu season. In saying that, I hope I'm wrong and we don't have a bad season, but apparently the vaccine is not a match this year.
It's been a pleasure seeing all of you all again. I do not take anything for granted because some people were here last year. For some reasons they couldn't be here this year. But you're all here, we're healthy. We need to give thanks to God for that. So again, my outing in Lagos, Nigeria, we're running. You don't need to sit down and watch it. We're going to start eating, and you're going to see there's a pamphlet on the table. Are they giving it on the tables? Toby, did you give out the pamphlet? Yeah, give it just for people to know what we're doing, okay? So that whatever you want to do, because I still want to go back to Nigeria. It might not be next year, it might be the year after the next, but whatever you can do, go to my website, visit it and do whatever you can do for us. I really appreciate you very much. We all, God bless you, and we'll see you again next year. December 7th, 2018, in the mighty name of Jesus, we're going to be here again. We're going to be bigger, I promise you. Thank you very much. So, how do we start eating? Is the food ready? Who's organizing the food, please? Okay, let's go. How do you do it? How do you put it on the light? They will find the way to put the food in their mouth. Please put on the light. So, how are you going to do it? Are you going to call the tables? How do you do it? How are you doing it, gentlemen? What are you waiting for again? Yes. Please, I am giving out tickets for drinks this year, just to have some control. There's a lot of tickets. If you want drinks, there's a lot. We can give you tickets to drink, but I just didn't want the bar to be open. People will drink and go. I want us to drink and dance tonight. Please, we have to dance. Every year, this party dies once people finish eating. No, I want to see you dancing. That's the third leg. You eat, you learn, and you dance. So please, you are all going to dance as much as you can tonight. That's why I held on to the ticket, so that these people can have some drink and enjoy themselves. Listen, I brought out the best DJ in the whole of Atlanta, a female DJ. They don't come very often. That's DJ Ijoma. She's the best. She's going to rock you tonight. She's fun. She has promised you a lot of fun. Okay? So let's get going and let's eat. Thank you very much, Father. I appreciate you very much. Okay? God bless you. Yeah, thank you.
The girl say my like the heat better watch it. You know I'm so expensive, but I can't handle my flow ridiculous. My boy got a gift like it gotta be Christmas. Swag on bitch like it gotta be gifted. The girls on cameras and they want pictures and they gon' frame them. See that? Now I'm in the bed while I'm saying my scriptures. Cause I be holy like a prayer in the temple. One I move with a letter of pencil. And my won't miss you. Good night kisses. Take it damn back, cause you got kissed it. And now I'm thinking about it, think around these issues. Wobble baby, 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 wobble baby.
The Slide Part 2 featuring the paper band, and this time we're gonna get funky. Funky. Everybody clap your hands. Clap, clap, clap your hands. Clap, 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 clap your hands. All right, now we're gonna do the basic step. To the left. Take it back now, y'all. One hop this time. Right foot, let's stomp. Left foot, let's stomp. Cha-cha, real smooth. Turn it out. To the left. Take it back now, y'all. One hop this time. Right foot, let's stomp. Left foot, let's stomp. Cha-cha now, y'all. Now it's time to get funky. To the right now. To the left. Take it back now, y'all. One hop this time. One hop this time. Right foot, 2 stumps. Left foot, 2 stumps. Slide to the left. Slide to the right. Crisscross. Crisscross. Cha-cha, real smooth. Let's go to work. To the left. Take it back now, y'all. 2 hops this time. 2 hops this time. Right foot, 2 stumps. Left foot, 2 stumps. Hands on your knees. Hands on your knees. Get funky with it. Oh, yeah. Come on. Cha-cha now, y'all. Turn it out.
And I Thank you.